Hi, welcome to the first Cooper Heart Institute live Facebook chat. Thanks for joining us. Don't forget to like us on Facebook. I'm here with Dr. Michael Rosenblum.
Hi, thank you for that. I'm Dr. Michael Rosenblum. I am the Chief of Cardiac Surgery at Cooper and also the co-director of the Cooper Heart Institute. And I'm really excited today about this exciting format that we're using. It's a first, and hopefully this...
Yeah, he couldn't stop talking about it, you know? He just couldn't stop talking about it.
And hopefully this is a very pleasant way to have an interaction and get out of this what we do and what's unique at Cooper with our heart program. So it's going to be an exciting moment for us.
So I'm Kathleen Hines. I'm a clinical cardiologist at Cooper. I've been at Cooper for more than 20 years. In that time, I've taken care of many patients, chest pain, angina, coronary artery disease, valvular disease, heart failure. Just a few words about the Cooper Heart Institute. We're the only academic comprehensive cardiac institute in New Jersey, in South Jersey. We have offices, non-invasive testing labs all over South Jersey, including Voorhees, Cherry Hill, Camden, Washington Township, and Woodstown. We have one of the busiest cardiac cath labs in the region, both for diagnostic caths and complex interventions. We have a heart rhythm center, treating atrial fibrillation, ventricular heart rhythms, placing devices. But today, we're here to talk about cardiac surgery at Cooper, and specifically minimally invasive cardiac or heart surgery at Cooper. So Dr. Rosenblum, I'm going to ask you to tell us a little bit about your background, how long you've been a surgeon, how long you've been at Cooper. But more importantly, as I was coming in this morning at 7 a.m. and we passed in the stairs, you were leaving, I was coming. What did you do last night?
Well, thanks for the personal question. One of the things that we have at Cooper is probably the biggest and most advanced aortic surgery center in South Jersey, if not in the Delaware Valley. And part of that means that we take care of acute aortic emergencies. And last night, I guess it was around 11 or 11:30, received a call about a patient with a condition known as an aortic dissection. It's a condition in which the layers of the aorta in the chest separate, and it's a potentially lethal condition, as you know, and requires emergent surgery.
Do you want to show us on that heart?
The aorta is the main blood vessel coming out of the heart. This is probably a better model here. And although this is designed to show heart valve surgery, the aorta as it comes out of the heart, in this particular patient, the layers separated. It's acute emergency. The patient will die if it's not treated within.
So what did you actually fix last night?
So we replaced the proximal portion of what we call the ascending aorta. When we operate on the top part of the aorta, we have to either maintain blood flow to the brain during the operation, or what we do in a situation like this is we cool the patient's body temperature down. Everybody's heard of the story about the person who falls to the bottom of the lake and they're hypothermic. Their body temperature goes low and they're resuscitated from being at the bottom of the lake, and their brain function comes back. It's a similar situation.
You don't have a lake up there.
We don't have a lake, but we have a heart-lung machine, and we can control, I always say we control the vertical and the horizontal. We can control the patient's body temperature and actively cool them down, and then we have techniques to make sure that we're also perfusing, providing blood flow, some blood flow to the brain. And at the cold temperatures, that protects the brain and other body organs so that we can safely shut off the circulation for up to 45 minutes safely and have the patient recover brain function.
So how long were you in there?
The actual surgery took about 3 or 4 hours, but through the intricacies of having to rewarm and everything in a big person, that can take a little bit longer, so probably about 5.5 hours. And that was last night.
That wasn't exactly what we call minimally invasive?
No, that's about the maximally invasive that you can have, but that's a
little off script, you know?
Yeah, well, it is an example of one of our other feature programs at Cooper, and that is our aortic program. And we work together collaboratively with the vascular surgery team, who are also very advanced in their techniques and technology in operating on the entire spectrum of aortic pathology. Dr. Bowen is actually our head of our aortic surgery program, our chest aortic surgery program, and works together very involved with the vascular surgeons.
Okay. Now I'm going to ask you a little bit more about minimally
Can I
invasive
answer
surgery.
the other question?
Oh, please, go ahead. Sorry.
Well, thank you. Just wanted to give a little bit of a background
On you.
on me and also our program, which I'm very proud of our program here. But I actually graduated medical school a long time ago. I've been doing heart surgery for almost 30 years, and specialized throughout my career. Nowadays, people tend to sort of focus on one particular area, but us old timers had the opportunity to really get the full spectrum of cardiac surgery. So I've done everything from heart transplantation to aortic surgery, but my main focus over the last, I would say, 15 or 20 years has been minimally invasive surgery, and in particular, mitral valve repair. That's the thing that I'm most passionate about, mitral valve repair.
Well, most patients do want a doctor with a few gray hairs.
Yeah, I think the hairs that I have are gray.
Okay.
But we established this program here. There was an existing heart surgery program here that was a very good quality program. In 2007, they recruited me to develop minimally invasive surgery here at Cooper. And I was very fortunate to be able to bring two other just first-rate surgeons who shared my philosophy, Dr. Heibloom and Dr. Bowen, shared my philosophy regarding minimally invasive approaches to a variety of pathologies. We do minimally invasive and robotic coronary bypass surgery. We do robotic lung surgery. We do minimally invasive valve surgery. So our focus has been towards minimally invasive surgery, and we have done nearly 1,200 minimally invasive heart surgery operations here in the little more than 10 years that we've been together with this program. So I've been in the academic realm since I left training. I was at Washington University for a decade, and I worked in Florida for 11 years and then came to Cooper in 2007. And I have to say that the tools that we've been given here to accomplish what we want to accomplish at Cooper have been fantastic. They've given us all the things that we need to be able to develop minimally invasive and robotic surgery in our arena. And also, as we'll talk about in a moment, in terms of a multidisciplinary team, I'm surrounded by just first-rate specialists in every realm that we interact with.
So when you say minimally invasive, does that just talk about the incision that you make?
For the most part, yes. Traditional heart surgery is performed through a sternotomy incision, where we divide the breastbone. It sounds awful. I've made thousands of them because I've done many thousands of heart surgeries. It is probably the best tolerated large body cavity incision that we perform. When we're done, the bone is wired tightly together. There's not a lot of movement. Most people say that it didn't hurt as nearly as much as they thought it would. And now I'm talking about conventional surgery. Having said that, in the 1990s, we tried to figure out a way that we could do even better with that, because with conventional surgery, where we make what's called a sternotomy, dividing the breastbone, patients do need time to recover. It's a broken bone. Just like a broken bone anywhere in the body, you're not going to be able to bear weight on it. We restrict patients from driving for a month after conventional surgery. And we also, there are other restrictions that we put on. We won't let them lift anything more than about 15 or 20 pounds for a good 3 months. All the golfers have to pitch and putt for a while before they can get out and make the big swing. So we looked for a way that we could do it better. And when I originally started out doing minimally invasive surgery, I thought, here I am, I'm going to really focus on a way to take a young patient and get him back to work and get him back functioning as quickly as possible. But what we actually learned was not only could I do that with a young patient, but I could even take an older person. somebody you thought might not even be able to tolerate a big open heart operation, and get them through that big open heart operation with a small incision without dividing their breastbone, and the recovery, have a quicker recovery, have less of an impact on their life, have less of an impact on their ability to breathe and do the things that they want to do. After a minimally invasive operation, whether it's aortic or aortic valve replacement or a mitral valve operation, where the incision is not through the middle, it's through the right side, we generally let people drive a week after they're at home, and the lifting and swinging the golf club restriction is much shorter.
So is
a couple
the
months.
driving restriction, is that due to the steering wheel?
Steering wheel, and I think many people after a conventional operation feel a little reluctant to turn around, to look to see if somebody's coming, and the seatbelt, that kind of thing. But that's not the case when your sternum is left intact. I feel very comfortable in letting people do it.
So your specialty is mitral valve repair. If you do a
That's my
minimal,
passion.
well, I'm glad to hear that.
Thank you.
What if you do a minimally invasive mitral valve repair? Does it mean the patient stays in the hospital any less time? Do they have more or less pain with that operation?
So just as technology has advanced in giving us tools that we can use to make smaller and smaller incisions, we're constantly evolving in our ability to do this better and better. And one of our recent advances has been the use of a long-acting local anesthetic to help to mitigate pain. In even a small incision, there's going to be some pain associated. So we have the ability now to use a long-acting local anesthetic, and we actually block the nerves. Sometimes we even freeze the nerves if we're using that device. And the patients tolerate the minimally invasive incision really well as a result of that. They don't have a lot of pain in the beginning. Just by way of a demonstration, when we do minimally invasive mitral valve surgery, we make an incision that's probably about 3.5 inches. We generally put it in the right chest, right in that crease. In women, that crease we try to get is right where their breast folds over. And for aortic valve replacement, the incision is a little bit more towards the front. And again, an incision is about this big.
You always seem to do a pretty good job of hiding it.
Thank you.
For the men, you hide it underneath the hair sometimes?
Yeah. We, it's not that most people are so concerned about the cosmesis of it, but, I think it's nice when you can make it cosmetic. And I tell patients, you're going to go to your doctor. He's not going to believe you when you tell him that you've had your valve operated on or your valve repaired, because they're accustomed to seeing the conventional incision, and here you don't have that. You have a small incision on the side.
So let's say I'm a patient with, I know I have severe mitral regurgitation. I'm considering surgery. Why would a repair be better than a replacement?
That's an excellent question. Thank you.
I bet you've never heard that question
No,
before.
I can't say that.
Okay.
So I always tell patients that their valve is better than anything I can take out of a jar. If I'm going to replace somebody's heart valve, and let's just say I'm going to use what we call a bioprosthetic valve. So the valve originates from a biologic source. In this case, this is a cow-derived valve. If I'm going to replace their valve, I'm often going to use something like this. If I'm going to repair their valve, I'm going to, I guess the best word I could use is realign the relationship of the leaflets of the valve so that they come together. The problem with a leaking mitral valve is that the leaflets aren't coming together properly. So either by removing pieces of it, by adding supporting structure to it.
I have the leaflets over there on that.
And
yeah.
And this actually, you can see.
So he's talking about repairing right here. It's actually the structure. These leaflets are attached to the valve, and they're attached to the ventricle here. And what he actually does is you repair these to make the valve more efficient.
And in the end, when we complete the procedure, we generally put some type of supporting structure around, which is either a ring, such as this, or a band type of device. And that provides mechanical support to the repaired valve. But it's been shown very clearly that when you preserve your own heart valve, you're at risk of the complications of an artificial valve, of course, is not there. So there's less risk of blood clots, less risk of infection in the valve. Your own body's tissue is much more resistant to infection, and better preservation of heart muscle function. So I always tell patients, choice 1, 2, and 3 is to repair your valve if it can be repaired. And it's not only can it be repaired, but can we give you a durable repair? It's not right to do a repair that you think is only going to last a few years and knowingly have to say, okay, well, we're going to come back. You want to do a repair that you know is durable. And there's outstanding evidence in the medical literature that if you leave the operating room with a repaired valve and the valve is not leaking or only minimally leaking, that there's a very high probability that 20 or 30 years from now that valve is still going to be functioning. Artificial valves, I often say, this is like shoe leather. You can't wear a pair of shoes for 30 years. Biologic valve has a lifespan. Mechanical valves, which we would generally use in a younger patient, are more permanent, but they require you to be on blood thinner. Coumadin in particular, which many patients don't want to be on. But
so do you know going into an operation most of the time if you can repair it or not? Can you guarantee a patient?
So it's going to be repairable until you actually lay eyes on it. But I can have a very high probability of knowing whether the valve can be repaired. There are certain appearances of the valve, certain pathologies that we see in the mitral valve that, they're pretty straightforward. And, I've been repairing valves since, 1990. So, we pretty much have seen most of the types of pathology of heart valves. So the other thing that's really advanced is your ability to produce outstanding echocardiographic images that you give us before the operation. I'm appreciative of that. With the new three-dimensional echo that we have in our new machines here that Cooper's brought into the hospital, we get almost lifelike images, as you know, of the mitral valve. So I get a very good idea going in from your echoes if the valve can be repaired.
Now, is the repair now a lot different than 10 years ago, 20 years ago?
So again, techniques evolve. There are some newer techniques where we at times will attempt to preserve structures that formerly we would have cut out with the valve, but these are more intricacies. I think yes, the technology and techniques have advanced, and I would say yes, I am more likely to be able to repair valves now than I had been in the past because of that.
So one of your patients from several years ago, Bob.
Hi, Bob.
He sent a note in saying you did his AVR several years ago. Said thank you, he's doing well, better than ever.
Oh, I'm glad to hear that.
So we have another question from an 84-year-old woman. What's that? 54. Sorry about that. She had a heart attack 1.5 years ago. She had a heart attack, went into, they call it diastolic heart failure. Am I going to need heart surgery? I'll take this one.
I think, I was going to say, that's a question for you.
Yeah, so diastolic heart failure it means fluid backs up into the lungs, not necessarily from a weakened heart muscle, but from a thickened, stiffened heart muscle. Generally, that's something that we treat with medications and try to prevent heart failure. Sometimes that is related to heart valve problems, sometimes it's related to other things. So most of the time you do not need heart surgery unless that heart failure is caused by a heart valve problem or a problem with the arteries that actually supply the heart muscle. So if somebody has a mitral valve, let's say do you think?
So tissue valves deteriorate.
By tissue, do you mean
The bioprosthetic valve,
Okay.
the cow-derived valve, or people have some people have big pig cow-derived valves. They tend to be durable for a longer period of time, but they deteriorate faster if you're younger. As you can imagine, your body's more metabolic, hypermetabolic when you're young, and they deteriorate faster in a 50-year-old than they would in a 70-year-old. our statistics would show that if you are 60 or 65 when the valve gets implanted, there's a surprisingly smaller risk of that valve needing to be replaced in the patient's lifetime than you would think. It's certainly less than 10%.
Most of the time we'll say they'll last 15 years, but we're seeing them last a little bit longer now, right?
Yes, yeah, we are seeing them last a little bit longer, but one, as far as technologies goes, one really exciting thing that we're now doing is, let's just say you're 65 when you get a tissue valve, and now you're 80, and that tissue valve's deteriorated. Well, it used to be we would have to reoperate on that patient, and going through heart surgery the second time isn't any more fun than going through it the first time.
It's a little less fun, right?
For some people. I think some people, knowing what it was like and anticipating that they would need it, helps them through it. But
it's probably a little harder for the surgeon, right?
yeah, there's scar tissue and things, but we can do it. It's not that we can't do it, but you have a patient now who's 80 instead of 65. In 2012, the transcatheter valves became available.
It just so happens we have one.
Well, we have this one here.
Yeah.
Yeah. So what we have is the ability to inject, is the way I like to put it, inject a heart valve into a patient. And certainly we can inject a heart valve into a deteriorated, we got 15 years out of this valve, and now for whatever reason his tissue valve is not functioning well. Rather than reoperating, it's like a cardiac catheterization or any other type of procedure where the patient isn't even completely anesthetized and going through the arteries in the groin most of the time, we can deploy an injectable heart valve across their previously replaced valve.
So you'd be going from the groin, bringing it back up through the aorta.
Exactly.
And like you say, injecting or implanting it through maybe the disease valve, right?
Correct. Either the diseased patient's own valve, as we do sometimes, or through a deteriorated tissue valve that we've implanted. And as we create a larger and larger population of people who are walking around with tissue valves, the need to do something in an 80-year-old is going to become much more common. And I think 5 and 10 years from now, there's going to be this is going to be a very common procedure. And as things become more common, and as the technology evolves, it becomes easier and easier. And a lot of our patients who have the transcatheter valve put in, as you know, some go home in a day or two. It's really astounding, rather than being in the hospital for several days after an operation.
So I have an important question. You work at a teaching hospital. Do you actually do the surgery?
Thank you for that question. I'm very proud of the fact that even though we're a teaching hospital and we do have residents in anesthesia and cardiology and a lot of the other specialties, at this point in time, we don't have a training program for heart surgery. So, unlike other academic hospitals, I'm there from the beginning of the operation to the end. And, I'm not turning over any part of the operation to, any resident or anything like that. I'm there. I'm the guy from the beginning to the end. I have been doing heart surgery, as I said, for 30 years, and we're a very busy heart hospital. This is what I do every day. And, I think that carries some weight with the patients. I think that's something they like to hear. A lot of times and I've worked in the other environment too, where you're training residents, trained residents for 10 years when I was at Washington University. Some of them are very famous these days. And you're giving over a portion of the operation to somebody else who's learning. But that's not the case.
You don't do that here.
We don't do that here.
So now, we always talk about a multidisciplinary team. Is that just words? What exactly does that mean?
It's one of the real benefits that Cooper brings in heart care, cardiology, and it really is truly multidisciplinary. When we sit preoperatively and talk about a patient, we have involvement between the clinical cardiologist, we have involvement with the interventional cardiologist, the surgeon, and we come to decisions that it's not one guy making a decision, it's a team approach. We each have our own perspectives, we each have our own mastery of the medical literature, and all that comes to bear for that patient. When the time comes that a procedure is needed, equally in the operating room, I've got the best cardiac anesthesiologists, we work with them every day, the same people. They know how we work, we know how they work. It's a very positive interaction. Cardiology comes into the operating room. You have the opportunity to come in often and review our work. And then when the patient finishes surgery, they go up to our critical care area. And Cooper is one of our feature programs is critical care. The patients are co-managed by cardiology, cardiac surgery, and critical care. I can't imagine you can get better care. It's
I always
something I'm very proud of.
I always say to patients, they'll say, I don't want to go to a teaching hospital, I'll just feel like a guinea pig. But I say to them, you want 5 or 10 doctors talking about you rather than maybe one physician who may or may not be up on the latest or up on the literature
Right.
or what's recommended. You want people talking about you, making a decision along with you, the best treatment plan.
And also available. I mean, a lot of times I'll do surgery and then I'm headed back to the operating room to do another surgery, and maybe something comes up, medication needs to be changed or whatever. I know that I've got the best cardiology, the best critical care, and the people working along with them to make things work out.
So what do you see on the horizon at Cooper for the next 5 to 10 years?
Well, it's mostly technology. I think we're going to see more transcatheter procedures. They'll advance transcatheter valve procedures for aortic valve replacement. We've started out with high risk in 2012. We were actually the first, what's called TAVR, as you know, the transcatheter aortic valve program. We were the first one in New Jersey, and we were, for a long time, the leading commercial program in the country. A very busy TAVR program. Our TAVR docs go around the world proctoring and helping other people learn those skills. And so I think those technologies are going to advance and develop, and we're going to see the application of those technologies not only in high-risk patients. We're already seeing them in moderate risk, and we're going to be able to bring that to even lower-risk patients as the data proves that that's an acceptable alternative to more conventional surgery. Also for us, we have new valve technologies. We have just this year, we participated in the clinical trial, but also this year we've started to use a sutureless aortic valve, which cuts down the time of aortic valve replacement, where we just put a couple of guide sutures in, pull the valve down in, and then we blow up a balloon and deploys the valve. So this really takes a lot of time off the operation. Time in heart surgery is important because patients on the heart-lung machine, you want the operation to be as expeditious as possible.
So Mike, we have to wrap up here. In terms of...
It went so fast.
I know. So we hope that this is just the first in many more Facebook live chats.
I hope so.
If you're able to see it, like us on Facebook. We hope to be back sometime soon. Thank you.
Hopefully really soon. Thank you for watching today.